Imagine waking up one day to find that a part of your body, a part that has functioned perfectly, predictably for maybe 40 years, suddenly just feels completely different.
Right?
There's no warning light, no like sudden injury, just an undeniable out of the blue sensation of a loss of support. And you're left thinking, wait, when did this start happening and why now?
It is really jarring experience, but biologically, it's a fascinating one. I mean, the
Yeah.
human body is incredibly resilient, and that resilience can actually mask underlying structural changes for decades.
Yeah, decades.
Exactly. The framework might be weakening, but the body just compensates until it hits a very specific tipping point. And once that threshold is crossed, the camouflage drops and the symptom appears seemingly overnight.
And today's deep dive is tackling a highly common but honestly rarely discussed question that perfectly illustrates that exact tipping point,
Right.
which is, can perimenopause make mild vaginal laxity more noticeable?
It's a great question.
We are synthesizing a massive stack of sources for you today. We're pulling from clinical guidelines from the British Menopause Society and ACE. We're deep diving into insights from pelvic floor physiotherapists and, unpacking the latest clinical research on genitourinary health.
There's a lot to get through.
There really is. The mission here is to just cut through the silence, the stigma, and the sheer lack of information to understand exactly what is happening at a cellular and structural level.
Okay, let's unpack this. We need to start with the timeline because the timeline is, well, it's a central mystery for most women.
Right, the delay.
Exactly. Vaginal laxity, which is essentially a feeling of looseness or lack of tone, is something culturally associated with childbirth. But the clinical data reveals a massive spike in women seeking help for this sensation during perimenopause and menopause.
Yeah. Which could be 10, 15, or even 20 years after they had their last child.
Right. Why the delayed reaction? Why is this happening so much later?
Well, to understand that massive delay, we have to look at the master regulator of the female reproductive tract, which is estrogen.
Okay. During a woman's reproductive years, estrogen is essentially the product manager for pelvic health. It's constantly signaling the cells in the vaginal walls to maintain elasticity, lock in moisture, keep the surface layers thick, and ensure a robust, healthy blood flow.
So it's keeping everything running smoothly.
Exactly. But when perimenopause begins, those estrogen levels don't just drop smoothly. They start to wildly fluctuate, and eventually they plummet.
Reading through the descriptions of how estrogen works, I started picturing it like a building's daily maintenance crew.
Oh, that's a good way to look at it.
Right. For decades, they're showing up every single day. They patch the drywall, they oil the hinges, they make sure the structural pillars are sound. And then menopause hits, and that maintenance crew just clocks out and doesn't come back.
They're gone.
Yeah, they're just gone. And almost immediately, the structural scaffolding, the collagen, starts to sag. The elastin fibers, which, give the tissue its snap, they begin to fragment. The tissue itself literally becomes thinner, drier, and just much more fragile.
That is a highly accurate way to visualize it. The histological changes, meaning what is actually happening under a microscope at the cellular level, are dramatic.
Wow.
Before menopause, the surface layer of the vaginal lining is thick. It's constantly renewing itself, shedding and replacing cells.
Just a continuous cycle.
Right. But once estrogen withdraws, that surface layer diminishes rapidly. The body stops investing energy into rebuilding it, and you're left with a much thinner, more vulnerable layer of cells. The tissue just loses its stretch and its capacity to withstand friction.
But hold on, I have to push back here, because this is where the terminology in the medical literature actually threw me for a loop.
Oh, how so?
Well, if the tissue is thinning out and the whole area is shrinking, which is the literal definition of atrophy, wouldn't that make the vagina feel tighter rather than looser? I mean, how does shrinking tissue lead to a sensation of laxity? It seems totally counterintuitive.
What's fascinating here is the paradox between the physical dimensions of the canal and the neurological sensation of support.
Okay, unpack that for me.
You're entirely right that the vaginal canal itself might actually be narrowing and shortening due to the tissue thinning. However, the loss of estrogen causes a critical loss of what we call vaginal rugae.
The rugae being those natural textured folds inside the vagina, like the pleats of an accordion.
Precisely like an accordion. Those folds are what allow the tissue to expand dynamically and, crucially, to grip.
Oh, to grip.
Right. When estrogen drops, the mechanisms that maintain those folds shut down. The rugae just flatten out. The walls become smooth, pale, and incredibly inelastic. So when you combine that loss of gripping folds with the fragmented elastin and the total loss of natural lubrication, you have a dramatic reduction in tissue resilience.
So it's an illusion of space.
In a way, yes, even though the canal might be anatomically narrower, the profound loss of friction, moisture, and flexibility creates a sensation of looseness.
That makes so much sense.
The nerve endings aren't registering the dynamic stretch and grip they're used to. It registers in the brain as a lack of support or laxity, especially noticeable during intimacy or even during regular daily activities like exercising.
That really reframes the entire concept. It's not that the physical space has somehow expanded out of nowhere, it's that the tissue has lost its dynamic grip. It's lost its tone.
Exactly.
And what is striking when you look at the broader literature is that this newfound sensation of laxity doesn't just happen in a vacuum. It almost always arrives with a whole host of other symptoms,
So definite.
which actually forced the medical community to completely rethink and rebrand how they talk about this entire phase of life.
They absolutely had to. I mean, for decades, doctors used very narrow, siloed terms like vulvovaginal atrophy or atrophic vaginitis.
Ugh, those terms.
I know. But 2014, consensus panels from major menopause societies finally acknowledged that this terminology was fundamentally failing patients.
Because it just sounded awful.
Well, yes, it didn't capture the full scope of what women were actually experiencing, and quite frankly, the words atrophy and vaginitis carry a stigma that makes patients hesitant to even bring them up.
Right. Nobody wants to go to their doctor and say, I think my body is atrophying.
Exactly. So they introduced a broader, far more accurate umbrella term, which is genitourinary syndrome of menopause, or GSM.
GSM. And the urinary part of that new name seems really vital because the research points out that estrogen receptors aren't just isolated in the vagina.
No, they're everywhere down there.
Right. They're peppered all over the vulva, the urethra, and the base of the bladder. So GSM covers the laxity and the dryness and the painful sex, but it brings urinary symptoms right into the same diagnostic umbrella.
It connects all the dots.
We're talking stress incontinence, sudden urgency, recurrent urinary tract infections. It's a massive, interconnected cluster of issues.
It is a syndrome in the truest clinical sense, a constellation of symptoms, all tracing back to the exact same hormonal deficit. It perfectly illustrates how intertwined the pelvic organs are.
How so?
Well, when the tissues supporting the urethra thin out because of that estrogen drop, the urethra simply cannot close as tightly. It loses its watertight seal. So suddenly, a cough, a sneeze, or a laugh leads to a leak.
Which brings up a statistic that absolutely floored me. Up to 80% of postmenopausal women experience GSM.
Yes.
80%. That is practically universal. Yet the British Menopause Society notes that it's considered a silent epidemic
It really is.
because only a tiny fraction, somewhere around like 7%, actually seek medical treatment for it. If this is happening to almost everyone and it's this disruptive, why the silence?
There are two main drivers behind that silence: timing and societal conditioning. When we think of menopause, we are culturally conditioned to think of vasomotor symptoms.
The hot flashes.
Right, the classic hot flashes and night sweats. Those usually hit right around the final menstrual period. They're immediate and highly disruptive. But GSM symptoms often operate on a completely different timeline,
They show up later.
much later. They might not become severe or noticeable until 5 to 10 years after menopause.
So because of that massive delay, the connection to menopause is completely lost.
Precisely. A woman in her mid-60s might start experiencing painful intimacy, frequent UTIs, and a feeling of vaginal laxity. But because she hasn't had a hot flash in a decade, she doesn't link these new issues to her estrogen levels.
She just thinks it's normal.
She assumes it's just an inevitable, irreversible part of aging that she simply has to put up with.
And the data emphasizes a crucial difference between those hot flashes and GSM. Hot flashes usually fade over time as the brain, eventually adjusts to the new hormonal baseline.
Yes, they taper off.
But GSM is chronic and progressive. Without treatment, the tissue doesn't adapt. It just continues to thin and degrade.
It does. It's a one-way street unless you actively intervene.
Which brings us to the actual interventions.
Okay.
If the tissue is degrading this much, why is the very first recommendation in almost every physiotherapy guide to do a muscle exercise? The literature constantly recommends Kegel exercises for vaginal laxity. They call it the primary non-invasive treatment. But if the root problem of GSM laxity is the vaginal mucosal wall losing estrogen, losing its folds and thinning out, how does clenching a muscle actually help fix a hormonal tissue issue?
It seems disconnected.
It feels like trying to fix a flat tire by upgrading the car's suspension. You might get a smoother ride, but the tire is still flat.
This raises an important question, and your analogy highlights a very common misunderstanding of pelvic anatomy.
Okay, school me.
To understand why physiotherapy is the first line of defense, you have to understand the pelvis as a layered system. You are entirely correct that pelvic floor exercises, or Kegels, do absolutely nothing to alter the cellular structure of the vaginal mucosa.
They don't bring the estrogen back?
They will not bring the estrogen back. They won't restore the surface tissue.
So we are separating the vaginal wall itself from the pelvic floor, holding it all up.
Exactly. We have to differentiate between vaginal laxity, which is the thinning of the mucosal tissues we've been discussing,
Right.
and the structural muscles underneath.
Right.
Think of the vagina as a flexible tube passing through a thick muscular sling, known as the levator ani muscles. If the walls of the tube have become thin, smooth, and floppy due to estrogen loss, you can compensate for that lack of internal volume by thickening the muscular sling that wraps around it.
Oh, I see. So you're bulking up the outside to squeeze the inside.
That is the exact mechanism. By doing targeted pelvic floor therapy, often with the guidance of a specialized physiotherapist who can ensure you're, isolating the correct muscles, you increase the resting muscle bulk.
You're lifting the baseline.
Yes. You increase the baseline tone of the pelvic floor. This thicker, stronger muscular foundation provides a much greater feeling of tightness, friction, and structural support during everyday activities, even if the vaginal lining itself remains postmenopausal and thin. It effectively masks the tissue laxity with muscular strength.
And that also helps explain the distinction the guidelines make between laxity and pelvic organ prolapse. Prolapse being a structural failure where organs like the bladder or rectum literally bulge down into the vaginal space. Childbirth stretches that muscular sling to its limits, and then aging or chronic straining weakens it further. Rebuilding the muscle helps hold those organs in place.
Exactly. A strong pelvic floor is your primary defense against prolapse.
But obviously, building muscle only goes so far. It doesn't fix the dryness or the micro-tearing during intimacy or the susceptibility to UTIs.
No, it doesn't.
For that, you have to address the actual tissue. And looking at the treatment arsenal and the clinical guidelines, it ranges from simple drugstore creams all the way up to space-age lasers.
It's quite a spectrum.
It really is. Let's walk through that clinical pathway.
All right.
What is step one for treating the tissue?
Step 1 relies on the simplest, least invasive options. For mild symptoms, the guidelines recommend non-hormonal vaginal moisturizers. These are products like Replens. And the mechanism here is quite clever. They use polymers that adhere directly to the mucosal cells. They hold on to water and slowly release it, changing the fluid content of the surface layer over a few days.
No, that is clever.
And of course, during intimacy, water or silicone-based lubricants are essential to provide the slip that the flattened rugae can no longer provide.
But if you move past mild symptoms, the medical consensus clearly points to a gold standard, which is localized vaginal estrogen.
Yes. For moderate to severe GSM, localized estrogen is remarkably effective and incredibly safe. It's vital to distinguish this from systemic hormone replacement therapy, or HRT.
Which is the pill or the patch.
Right. HRT is taken orally or via a skin patch and circulates through your entire bloodstream to treat hot flashes or bone density. Localized estrogen is a microdose delivered strictly to the vaginal tissue.
Using creams or those small dissolving tablets like Vagifem or flexible silicone rings like Estring that you just leave in place for 90 days.
Correct. Because it's applied directly to the affected area, the systemic absorption into the rest of the body is minimal. But the localized effect is profound.
What does it actually do to the cells?
It literally reverses the cellular atrophy. It signals the body to rebuild that thick surface layer. It restores the rugae, brings back the robust blood flow, and thickens the epithelium. It's treating the absolute root cause of the syndrome.
Here's where it gets really interesting, though.
Yeah.
When you venture outside the standard conservative clinical guidelines and look at the aesthetic or regenerative gynecology sector, there is a massive, aggressive push for high-tech interventions, energy-based devices.
You're referring to the thermal and laser treatments.
Yes. The radiofrequency devices like Thermiva and the fractional lasers like CA2 and erbium lasers, the marketing on these clinic websites is wild.
It's very persuasive.
They pitch these procedures as quick, painless miracles. They say it feels like a warm massage, takes 20 minutes, requires zero downtime, and boasts 90% satisfaction rates for tightening the tissue and fixing mild incontinence.
That's the claim.
And the claim is that the heat, causes a controlled thermal injury, which tricks the body into rushing in and producing brand new collagen and elastin. But then you cross-reference those clinic claims with the NICE guidelines, the National Institute for Health and Care Excellence in the UK, and NICE is waving a massive red flag.
The contrast between the commercial marketing and the regulatory literature is quite stark, and it demands careful scrutiny.
It's jarring. NICE specifically outlines case studies of women suffering from severe, debilitating complications after these exact laser treatments.
Yes, the adverse events.
We're talking about women who engaged in intercourse weeks after the laser procedure and suffered severe vaginal lacerations. Another case documented a 68-year-old woman who developed a crescent-shaped fibrous band, basically a thick web of scar tissue right in the middle of her vagina.
Which is incredibly painful.
It created a stricture that made her pain exponentially worse. Another patient ended up with a shortened vaginal canal of only 2 to 3 centimeters due to internal scarring. I mean, how do we reconcile the mechanism of a warm massage with the reality of fibrous scar tissue?
Reconciling that requires an impartial look at the biology of wound healing and, crucially, a deep understanding of patient selection. The theory behind energy-based devices is scientifically sound. It's called neocollagenesis.
Creating new collagen.
Right. When you apply controlled thermal injury to tissue, you create microwounds. The body's natural healing response is to send in fibroblasts, which lay down fresh, elastic collagen to repair the damage. For some women, particularly breast cancer survivors who cannot safely use even localized estrogen, these devices have provided significant life-altering relief from laxity and dryness.
So the underlying mechanism can work. The body can be tricked into rebuilding the scaffolding.
It can. However, the NICE guidelines are highlighting a critical variable, which is the baseline health of the tissue being lasered. Robust, long-term, randomized controlled trial data is still building, and the heat applied by these devices must be incredibly precise.
Because if the tissue is already compromised.
Exactly. If the vaginal tissue is already severely atrophied, if it is fragile, paper-thin, and entirely devoid of estrogen, hitting it with a laser can cause far too much thermal damage. The tissue simply doesn't have the biological resources to heal properly.
It's like trying to weld a piece of metal that has completely rusted through. You aren't going to get a strong joint. You're just going to burn a hole in it.
That is a very apt comparison. Instead of laying down healthy elastic collagen, the overwhelmed tissue responds by laying down rigid fibrous scar tissue.
Wow.
This is exactly what causes those strictures, the crescent-shaped bands, and the worsening pain documented by NICE.
Which makes the initial diagnosis incredibly important.
It is the absolute priority. A patient coming in and complaining of a sensation of laxity needs a comprehensive pelvic exam by a specialist before anyone goes near them with a laser. The physician must determine the true underlying cause.
Because it could be a number of things.
Right. Is this purely estrogen-related cellular atrophy? Is there an undiagnosed physical prolapse of the bladder? Are the pelvic floor muscles actually hypertonic, meaning they're in a constant state of spasm, which can mimic the pain and tightness of atrophy? You cannot just point a thermal device at a symptom without knowing exactly what the underlying anatomy is doing.
So where does that leave the treatment hierarchy for someone listening to this right now?
It means that while energy-based devices hold promise and are heavily marketed, localized estrogen remains the safest, most thoroughly proven, and most cost-effective foundation of care for GSM.
It's the bedrock.
Yes. In fact, many clinical experts now suggest that if a patient is going to pursue laser therapy, they should ideally be pre-treated with localized topical estrogen for several weeks beforehand.
Oh, to build up the tissue first.
Exactly. This plumps and thickens the tissue, making it robust enough to safely absorb and heal from the thermal energy.
You have to prep the canvas before you start painting. That makes total logistical sense. So let's tie all these threads together for you, the listener. The question we started with. Can perimenopause make mild vaginal laxity more noticeable? Based on the clinical data, the answer is a resounding yes.
Absolutely. The drop in estrogen strips away the vaginal tissue's structural resilience. It removes the collagen, the elastin, and those vital gripping folds.
It takes away the support system.
Right. So if you had a slight dormant structural weakness from childbirth decades ago, or just from the natural aging process, the loss of estrogen acts as an amplifier. It turns an invisible anatomical shift into a highly noticeable, bothersome sensation of looseness, dryness, and discomfort.
But the most important takeaway from this entire stack of research is that you do not have to accept this as just getting older. This isn't a life sentence.
Not at all.
Whether you opt for targeted pelvic floor physiotherapy to rebuild the muscular foundation, or localized estrogen to restore the cellular integrity of the tissue, or eventually explore clinical procedures, there are highly effective, evidence-based ways to restore your function and your confidence.
The first step is simply breaking the silence. And thankfully, that conversation is becoming easier as the medical community adopts terms like genitourinary syndrome of menopause.
Which validates the physical reality of these changes without the stigma of the older, outdated terminology.
Exactly.
Before we wrap up this deep dive, there was one tiny detail hidden in the clinical research that I really want to ask you about. We've talked extensively about how dropping estrogen changes the physical structure of the tissue, but there was a footnote about how it also alters the microscopic ecosystem, the bacteria.
The vaginal microbiome. This is arguably the most compelling frontier in genitourinary health right now.
What exactly happens to the bacteria when the estrogen disappears?
It's a fascinating chain reaction. In a healthy premenopausal vagina, estrogen stimulates the cells to produce a sugar called glycogen.
Okay, glycogen.
Glycogen is essentially the primary food source for the healthy, protective bacteria in the vaginal tract, specifically Deuterlein's bacilli, which are a type of lactobacilli.
So the estrogen is feeding the good bugs.
Exactly. And those good bugs consume the glycogen and produce lactic acid as a byproduct. That lactic acid keeps the vaginal pH highly acidic, creating an environment that is incredibly hostile to bad bacteria.
It's an immune defense.
Yes. But when estrogen drops during perimenopause, the glycogen production stops. The lactobacilli starve and die off. Without them, the lactic acid disappears, and the vaginal pH rises, becoming far less acidic.
And that rolls out the red carpet for the bad bacteria to move in.
Precisely. Suddenly, bacteria like E. coli from the digestive tract can easily colonize the area, which is exactly why postmenopausal women experience such a massive spike in recurrent urinary tract infections.
That leaves you pondering a really provocative thought. If the root of the infections and the tissue health is tied to this bacterial ecosystem, could the future of treating vaginal laxity, GSM, and overall pelvic health lie not just in hormone creams or lasers, but in bioengineering the postmenopausal vaginal microbiome?
It's a huge possibility.
What if we could seed the environment with specialized bacteria that naturally produce the acids and structural support the body needs, essentially tricking the tissues into behaving like they're still bathing in estrogen?
It's a brilliant question. Shifting the focus from just treating the human cells to treating the entire symbiotic environment could completely revolutionize how we approach menopausal care in the next decade.
Something for you to explore on your own. But for now, remember where we started. That quirky physical change, that sudden shift in your 40s or 50s, it's not in your head and it's not a mystery.
It's biology.
Exactly. The hormonal maintenance crew may have clocked out, but you have an entire toolkit available to rebuild the scaffolding.